An identical tumor arises in the ovary where it is called dysgerminoma. And in the central nervous system, usually in midline structures such as the pineal gland, where it is referred to as germinoma. Seminoma is the commonest malignant tumor of the testis and corresponds to dysgerminoma in the female. It constitutes about 45% of all germ cell tumor. And in another 15% comprise the major component of this germ cell tumor. Seminoma divided into two main categories, classic and spermatocytic. Classic seminoma comprises about 95% of all seminoma and has a peak incidence in the fourth decade of life. Undescended testes harbor seminoma more frequently as compared to the other germ cell tumor. Morphology: seminoma produce bulky mass, sometimes 10 times the size of the normal testis. The typical seminoma has a homogeneous, gray-white, lobulated patch surface, usually devoid of hemorrhage or necrosis. Generally, clinical albuginia is not penetrated but occasionally extension to the epididymis, traumatic cord, or scrotal sac occurs. The classic seminoma cell is round to polyhedral and has a distinct cell membrane, clear or watery appearing cytoplasm, and a large central nucleus with one or two prominent nucleoli. The cytoplasm contains varying amounts of glycogen. So this is the testis, normal, and this is the tumor part, homogeneous lobulated appearance. This part. Well circumscribed, pale, fleshy, homogeneous mass on the patch surface. This one. This one the tumor part. And this is the microscopic picture of seminoma testis. These are the seminoma cells. These are the fibrous septa, and these are the lymphocytes. Fibrous septa are infiltrated by lymphocytes. Now, uterine leiomyoma. Uterine leiomyoma, commonly called fibroid, is perhaps the most common tumor of women. They are benign smooth-muscle neoplasm that may occur singly but more often are multiple. Most leiomyoma have normal karyotypes, but approximately 40% have a simple chromosomal abnormality. Several circularity subgroups are unearthed, including tumors with rearrangement of chromosome 12q14 and 6p, involving HMGIC and HMGIY gene. Uterine leiomas, even when large or numerous, may be asymptomatic. Common signs and symptoms include abnormal bleeding, irregular frequency due to compression of bladder, silent pain from infarction of a large or pedunculated tumor, and impaired fertility. In pregnant women, leiomyoma may increase the frequency of spontaneous abortion, fetal malpresentation, uterine inertia, and postpartum hemorrhage. Malignant transformation to leiomyosarcoma is extremely rare. Morphology: leiomyomas are sharply circumscribed, distinct, round, firm, gray-white tumors varying in size from small, barely visible nodules to massive tumors that fill the whole pelvis. They can occur within the myometrium, that is called intramural, just beneath the endometrium, that is called submucosal, beneath the serosal, that is called subserosal. The characteristic whorled pattern of smooth muscle bundle on cut section usually make this lesion readily identifiable. Large tumor may develop areas of yellow-brown to red suffering. Leiomyomas are composed of bundles of smooth muscle cells that resemble the uninvolved myometrium. Usually, the individual muscle cells are uniform in size and shape and have a characteristic oval nucleus and long, slender, bipolar cytoplasmic process. This is the gross image of leiomyoma. These are all fibroid or leiomyoma. Microscopical picture. This is called Submucosal, Subserosal, and Intramural. These are all fibroid and leiomyoma. These are called submucosal. These are submucosal. These are intramural. Now, adenomyosis. Adenomyosis defined as abnormal distribution of histologically benign endometrial tissue within the myometrium, along with myometrial hypertrophy. The term adenomyoma is used for actual circumferential mass made up of endometrium and smooth muscle tissue. Pathogenesis remains unexplained. The possible underlying cause of the invasiveness and increased proliferation of the endometrium into the myometrium appears to be either a metaplasia or estrogenic stimulation. Clinically, the patient of adenomyosis generally complains of menorrhagia, colicky dysmenorrhea, and menstrual pain in the sacral or sacrooccipital regions. Grossly, the uterus is slightly or markedly enlarged with hypertrophy of myometrium and normal endometrium. Enlargement may be diffuse or predominant in one uterine wall, usually the posterior wall. Myometrium shows small cystic spaces with bluish discoloration, such as old hemorrhages. These foci represent endometrial glands in myometrium. Coarsely claviculated and diffusely hypertrophic myometrium, cervix and cervical canal appears normal. Microscopically, diagnosed based on the finding of normal benign endometrial island composed of glands as well as stroma deep within the muscular layer. The minimum distance between the endometrial island within the myometrium and the basal endometrium should be one low power microscopic field for making the diagnosis. Gross picture of adenomyosis. This is the endometrium, normal endometrium. This is the hypertrophied myometrium. This one. And these are the tiny cystic spaces representing endometrial glands. These are the diffuse thickened and claviculated myometrium, punctate hemorrhage. This is the endometrial cavity. These are the punctate hemorrhage. This means this is the specimen of adenomyosis. Here also. Here you can see claviculated appearance in myometrium. Here also small cyst-like spaces. What is this? Leiomyoma, fibroid. This is fibroid. This is adenomyosis. Endometrial glands are stroma found in the myometrium. It is myometrium, and in the myometrium you can see endometrial glands and stroma.